Hello, everybody. Welcome to the Cancer Patient Lab weekly webinar series. My name is Roger Royce. I'm on the board of Cancer Patient Lab. And before we get started, the housekeeping announcement are three things. Number one, none of this is medical advice. Please consult your own doctor for any advice specific to your situation. Secondly, this is public. So if you're here on the Zoom and you're using your real name, that is going to be public. So if you don't want that to be public, you should change your name and maybe even block your video. And then thirdly, the Cancer Patient Lab is a 501c3 nonprofit organization, so it is supported through contributions from the public. So if you'd like to make a contribution, please reach out to us and contact us, and we'll send you a link. With that, I want to introduce you to Brad and Ari, who are going to talk about the importance of cancer diagnostics. We've had a lot of sessions here, and, I've been beating the drum forever about the importance of diagnostics because, believe it or not, there's a movement out there that, gee, patients shouldn't have so much information. They don't need to know. Let's wait until they get wheeled into the emergency room before we tell them what's wrong with them. And that's changing. I mean, we're getting more engaged patients and more informed patients, and people are starting to say, I kind of do want to know, myself. I want my information. And Brad and Ari are working with, I don't know if you're going to talk about the accelerator or the company, but with a program that promotes those technologies. So with that, I'll let you guys take it away.
Thank you so much. Let me see if I can pull up the desktop. Okay. All right. Are you with me?
Yep. Still good.
Awesome.
Yes.
Awesome. All right, great. Thanks for that intro, Roger. And I guess by way of quick intro, I gave a talk here, a few months ago, I suppose. Brief background coming from a consumer technology background. Cancer survivor, went through diffuse large B-cell lymphoma a few years ago. And, that was my entry point into the wonderful world of patient advocacy, or patient self-advocacy, as it were, diagnostics, and all the fun that comes from that. I think by way of overview here, and you all know Brad, so I don't think he needs any intro. What we'd like to go through here is probably 5-10 minutes of slides to provide a quick overview of what Brad and I have been working on with respect to a new initiative in terms of addressing some of the problems that we see in the industry. This is, Roger, to your point, somewhat maybe adjacent to the accelerator. We certainly can talk about that, but we'll be talking more about the approach that we're taking with this new company initiative. So quick overview, 5-10 minutes of slides. Want to actually talk about this, may be a more intimate conversation given the size of the group, but want to talk about people's experiences in navigating your own cancer care and getting diagnostic tests in particular, the good, the bad, and the ugly. Would love to get some early feedback on our direction and the approach that we're taking. And then the other thing is that we're actually starting to shift from visioning to actually putting pen to paper, or pixels on the screen, however you want to think about it, workflows in motion, and thinking about actually partnering with folks, that actually would benefit from this kind of service. And so that's a bit of a call to sign up, learn more. Hello, Richard. Good to see you.
Hello, Ari. Nice to see you. Sorry, I had the wrong link.
Oh, interesting. Should we just pause there? Were there two links on the invite?
No, I was running on fumes, and I just had an old link, and that was what I always used, and then it didn't work. So I got the new link.
Well, we're glad you're here.
Yeah, this is Elaine. I had trouble too with the link, though that was sent out yesterday in an invite. It didn't work. It said the host has another meeting in progress.
Yeah,
So,
I got that too.
Yes,
Brad,
I did too.
resend it.
I got that as well.
Ah,
So you sent out the wrong link, FYI. Thank you.
Oh, I
Thank
thought it was,
you.
I was on, I thought it was on, I thought it was my mistake. Maybe it still was.
we may want
For
to.
comparison, the invitations I got populate to my calendar on Google. And so I clicked the link on my calendar and got in okay. So that might be worth comparing.
Okay, well, we may have mystery solved on the turnout. We'll press on. The approach that we're taking overall is really in thinking about what would it look like to design a system that's built around the patient rather than having the patient contort to the medical system itself. And so that's what we'll be talking about. Let me make sure that I can progress my slides. I would say our thesis at bottom is that diagnostics are the key to getting the best outcomes. The other observation is that while the diagnostic technologies themselves are exploding in what's available today, for example, tissue analysis and scans are used. DNA sequencing is still pretty low, but increasing. But overall, we think that things like liquid biopsies, functional testing, RNA, they're not really utilized. And, just an anecdote, went for a Dana-Farber checkup just the other day, ask the question of, well, why are we doing just standard panels for monitoring follicular lymphoma? I wouldn't know what to do with the liquid biopsy. It's not, part of the standard of care, et cetera. I think that the downstream impact on patients then, and not saying that this is directly causal, but certainly contributing, is you see clear trends with lack of patient trust. Something like 2/3 of patients do not even trust the system. We have a transactional fee-for-services system that introduces just really warped incentives, and people, I think patients see through that very clearly. In terms of the diagnostics themselves, we have high diagnostic errors. I saw a crazy statistic from the Mayo that something like 80% of second opinions result in a material change in diagnosis, which is fascinating. And in speaking with one of our close collaborators, Tony Magliacco, who many of you may know, we just find that as we pull on the thread, we find it's worse than we even suspected in terms of the diagnostic error rates. And then I would say that then when you think about the importance of a diagnostic and then mapping that into a treatment path, a treatment decision, the wrong diagnosis, you're off on the wrong foot on the treatment path. And I think many of the folks here maybe have experienced that with changes in diagnosis. There's also a lack of just proactive monitoring over time longitudinally, again, back to that transactional system. And that menu of options that is available to patients is limited based on the payer provider network and for other reasons regarding reimbursement and other things. Brad, color commentary, anything you would add there?
No, I particularly like the doctors don't know about tests. They're not standard, and yet those tests could be very valuable, particularly to stage 4 patients, patients beyond the standard of care. And so that's a really big gap.
Yeah. And so when we think, this is one of Brad and my favorite little graphics that we put together, we think about the green line being the curve of technical possibilities, which are moving very quickly. I was just reading about AlphaFold 3 or 4 the other day. I mean, it's astonishing. On the bottom line, the black line would be what you might think of as a standard of care. And you actually have, let's call it the best in class standard of care at the centers of excellence. You have variants inside of that, where actually you could have a bar on, how much that actually is. But I think our aspiration would be to think about how do you bend that curve from what the baseline adoption might actually be, which is to say kind of factory model, treating on averages, all the things that I've listed out here under standard care delivery that I won't read, but the pace of innovation, we think, is slower than it needs to be, and that directly impacts patients. And so the nerd in Brad, mathematician, is, well, how do we get the the integral, the area under the curve of that blue dotted line? How do we increase that in terms of impacting patient outcomes and patient experiences? And so that's what we're after here. Brad, anything to add?
No.
So in thinking about what it might look like to put the patient at the center, we kind of think of this in two parts. You have diagnostics on the one hand, which is this kind of circuit that you're seeing, this circular chart, and then a navigation platform. We think about, and so we've been working pretty closely with Tony, who I don't think is here. I'm not sure if he shows up to these, but thinking about getting that diagnostic trust locked in. And so that would start with a case review, ordering, and ability to not only order the tests that are kind of inside of your provider network, but actually surveying the entire landscape of what makes sense given a person's history and a deep understanding of their biomarkers. What do we actually need to make the most informed decision? Do those tests, make an informed decision, and then do the treatment, connect with the treating location. I think an interesting part of this is actually thinking about if a patient really has diagnostic trust and confidence, then you can point into different provider networks or treating locations as is useful. When I just think about like my own particular experience with this, you're diagnosed with something, you are disoriented, you really don't know where to begin, what's up and down. And as you learn more, you realize, it doesn't actually matter where you get your treatment for particular types of treatment. So the treatment regime that I got was 6 rounds of an R-CHOP chemotherapy. And the advice I got, I think it was from UCSF, was it doesn't matter where you get that treatment because it's the same everywhere. The part that actually mattered and had high variance in terms of interpretation and completeness was on the diagnostic side. And so it's kind of interesting to tease those two elements apart in terms of how it can impact what a patient actually needs. We've put expert guidance and co-pilot in the middle here. Over time, AI agents are getting better. And so you can imagine a world where you start with experts. Sometimes we think of tumor panels or tumor boards as a way of co-locating multiple experts to inform a particular treatment path, but really really anchoring on what a patient needs and mapping that set of options into that. So that's on the diagnostic side. And then on the navigation platform, we have several elements that I'll kind of just briefly fly over. Things like connecting to community, finding patients like you, patients that have gone down the path, I think, in terms of engendering trust. That's a really important element, not only getting the best experts, but also patients that may have some experience in going down the various rabbit holes relative to a diagnosis. A marketplace is something that we've been talking about that is quite interesting, which is what would it look like to break out of the provider system and provide a menu of options that are priced, we like to think of like a Costco model, priced cheaper than sort of retail, let's say, and do that discovery for patients that are looking for navigation services, different diagnostic tests. What might that look like? A records vault, community connection. And so that would be kind of the foundational platform piece. I'll stop there. Brad, what would you add?
No, that's got it.
Great. So that's a very brief flyover of how we're thinking about approaching this problem. And then what we really wanted to spend the bulk of the time on was talking with you all and understanding, number one, like when you're thinking about your own diagnostic journey from the first time you were diagnosed to monitoring and remission and that whole landscape and what that looks like. Would really love to like get some thoughts from folks on like what are the pain points that you all see when you're dealing with that. We've also put up a few other conversational bullets up here, but I think that's kind of the big one that we were hoping to round robin and just get some folks, some feedback from folks. Like, does this sound like a problem that you all have faced? And would love to hear from you. Just like, what are the pain points that you all see, have experienced as you go through this?
Well, okay, so use the raise hand feature if you could. So let me start. Kind of, because I'm like the diagnostics king here. I mean, I get every test that comes along, and a lot of them are, startups and unproven and unheard of. And one of the issues, well, two issues. One is you get false positives, and I've been through that a few times, and that's a little bit, concerning. But secondly, it feels to me like some of these tests have gotten just so good at finding stuff that they pick up noise, and they pick up things that your immune system is going to deal with just fine. And I'm wondering how you're going to deal with that if you're entering a diagnostic, because that seems to me to be the biggest problem in diagnostics. I don't, maybe it's not, but at least it's a problem. How are you dealing with that issue?
It's a good question. I think the real answer is triangulating on opinions and backstopping on experts that know the diagnostic space. So our mutual friend Protean actually is world expert in understanding the pathology reports, not only which tests, but interpreting the tests. And actually, I think if you just pull the thread a little more on your story, Roger, because I know you told us about the, I think you're talking about the one on New Year's maybe, where you had that false positive. And I think Tony was the one that suggested that it was noise, and kind of flagged that as the issue.
Yeah, and I went out to the community about it. It's on New Year's Eve.
Yeah.
Late
Yeah,
in the day
that's
on
what it
New
was.
Year's Eve, and I get this report that says, "Oh, you've got this, new mutation. I think it's P13 or something." And I couldn't get a hold of Tony. I talked to him at 7 a.m. on New Year's Day, and he said, "Yeah, don't worry about it. That's noise." But you need to do follow-up tests. So we did follow-up tests with some other companies, and they didn't find it. They didn't find anything. So he didn't trust the test. Basically, what it came down to. Says you're going to get that sometimes.
Can I ask you, was the recommendation to get that particular test, I don't know the details on it, but was it, did it originate from your oncologist, from Tony, from you, from community? Like,
No, it was my fault.
It
was my fault.
Okay.
One of my clients has a friend who has a startup that has this test, and so he contacted me and said, "Oh, you should do this." So it did not come from Tony; it came from me, and I take full responsibility for that one. But I think the moral of the story is you kind of need to get an expert in this to read this stuff and separate the wheat from the chaff, as Brad would say back in Minnesota. David's got his hand up.
Well, let me just comment on that as well. I think Roger's pointing at something really important, which is there's like the facts and then there's the interpretation. There's the test result, there's the report, there's that, that thing that's written down, and then what does it mean? And the one question on the mind of the patient, as it was in Roger's case, is this bad news? Should I be concerned? Or is this good news and I should not be concerned? And the only way you get that typically is from talking to, in my case, it was Emma Stivelman at Cancer Commons. It could be Tony. It could be my oncologist. I would trust him if he said, this is not concerning. But it does take an expert who's seen a lot of cases to put it in context. And it also takes someone who's knowledgeable about these tests. Because my oncologist, who's very cutting edge at Dana-Farber, when I said I can get an RNA-seq test through Tony Magliacco at Protean Biodiagnostics, he said, "Well, that's great, but I wouldn't know how to interpret it if you showed it to me." So interpretation is an important step, and it's pretty much done by humans these days after the diagnostic group does and gives you that report and those facts.
Yeah, and let me add to that. And David, I promise I'm going to get to you next. But so I got a proteomics report as well that I got through Cancer Patient Lab from mProbe. And it's, this big technical single-spaced report. And I gave it to my oncologist, and I should show you his email. He says, "What am I supposed to do with this?" He says, "I don't even understand it." And then I went to Cal Moody, and she explained it to me. And she said, "Well, go tell the oncologist to look at, page 3, line 26, and tell him, focus him on that." And I took it back to him, and he looked at me and he said, "Oh, now I get it." So it really is important to have the right people in the room, for sure. Okay, Dave, go.
I'll agree with that. It puts me in mind of Harry Truman's complaint about his economic advisors, and they would tell him, "Well, on the one hand this, and on the other hand that." And Harry Truman said, "I wish I could find an economist with only one hand." But I come at this more from the beginner's point of view, and the people in my support groups who come in not understanding the vocabulary. So I think a glossary is really important. They don't know what they don't know, and they don't know how to find out. And I like to tell them that the asking questions is good, but the quality of the answer is going to depend on the quality of the question. So helping them design good questions are a good thing. And also, it sounds like you're going to end up with competition from online search engines, what people like to call Dr. Google. And you can get good advice, you can get bad advice, you can get the full range in between, and no way to tell the difference. Um, and the other thing that came to mind from what you've said so far is when I brought up the idea of genetic testing with my oncologist, I was already well into my treatment plan. And the response I got was, "Well, at this point, whatever results you get are not going to change the course of your therapy. So there's no point in wasting time, attention, and money on background on tests that are going to give you background information, because we're just going to keep doing the same thing." So I went ahead and arranged to get some genetic testing through the Promise program and the color testing, and I turned that over to my oncologist. And someday that might become useful, but it was something I had to go and figure out for myself. So that, I think, is support for this being a good idea. It's just that people need to understand that sometimes it's going to provide background information or information that's only really useful in the future.
I had that
Yeah.
same exact experience, Dave. I had to ask the oncologist 5 times to get my tumor tissue sequenced because I was already in a course of treatment of chemotherapy, and it's like it's not urgent. They eventually did it, but it wasn't going to affect the treatment decision.
And it also means they're not likely to push against any financial restrictions placed on them by the insurance company. If the insurance company doesn't approve it, they're not going to want to try and persuade the insurance company otherwise, or get you to pay for it yourself.
So,
That's a good question,
David,
Brad.
I just want to come back to your first point, though, which I think is a key theme that runs throughout all this, which is trust. So, you can get, as in Roger's case or in your case, you get recommendations that you think are maybe fringe, maybe are they reliable? There's sort of a question of confidence. What are the characteristics, if we were trying to design something that maximizes trust? Who do you trust? What do you trust? What does trust mean to you when you're getting test results that may be, the confidence around them is not 100%, let's say, or the interpretation isn't? What dimensions are, and I would ask this really of everyone, what does trust mean to you, and what is trustworthy?
Well, I've got conflicting ideas on that. One is I like to see, multiple sources telling me the same thing. The danger is when they're telling you different things, which one do you choose and whom do you trust? And that brings me to, I think it's called Siegel's Law, which says, a man with one watch knows what time it is, and a man with two is never sure.
Anyone else on trust and what they find trustworthy? What would cause you to trust someone, or a recommendation, or a result?
I mean, that's really an interesting question, because it kind of gets into what's endemic for our age and society now anyway. I mean, how do we know what to trust? We typically, these days, on the political front, we trust the people in the cohort that we feel ourselves aligned to. And that's, and we can pick and choose our information. And to some extent, that may be what can happen in this world of diagnostics as well. I think that if a diagnostic test gets adopted by the trade being oncologists, I think people still tend to trust their oncologist up to a point, but only up to a point, because the treatments work only up to a point. As long as they trust their oncologist and the treatments are working reasonably well, and the oncologist believes in a test, I think that test will be a trusted test. It's when people get to the bleeding edge of where things start to work, they have to kind of roll their own trust, because by definition, almost, the oncologist can't easily adopt things that take them out of the comfort zone of standard of care. So, maybe you have to find a trusted, kind of more bleeding edge oncologist, or you have to do your own research. But if you do your own research, it's very, very difficult, because to do your own research, you all of a sudden have to start to become something like an expert. And this is such narrow stuff that the decisions that an average person makes are not those of an expert, but somebody who, just sort of rushes into something, which does sort of close the circle a little bit to what you and Ari are doing, and what, I spoke to this group about a few months ago, which is building a guide to diagnostic services. And, maybe that's what, in some ways you're wrapping around, the sets of things that you want to do. But to the extent there is something that can be a trusted authority, in the sense that people believe generally what it says and what it does, and that its recommendations are reasonable, and then oncologists start to adopt it, then it could be something that an average person can start to trust, even if they don't fully understand it. But right now, it's just sort of, whatever a company says is almost what you have to do, because it's really hard to get that. I was wondering, though, Roger, what motivated you for the test that you got? Do you just sort of get most of these tests to just sort of see what they say, or was there a particular reason you got the test that you got?
Monitoring for recurrence. I'm just at high risk of recurrence, so I keep a close eye on it. And, the standard of care is you come in every 6 months and get a scan. And first of all, 6 months is too long. And secondly, by the time it shows up on a scan, it's too late. I wanted something better. And getting back to the trust issue, for me, it's two things. It's number one, it's got to be a doctor that I trust. And I really like Tony. I think he really knows his stuff on the diagnostic side. And then secondly, I want to talk to other patients and see what their experience was, especially people that attend events like this and probably have seen quite a lot. So anyway, in answer to your question, Brad, that's what does it for me.
Yeah, that I anchor on that as well, where I think as I went in, and then it looks like Rick has a hand up, so I'll be brief and then go to Rick. But the thing that I found was, as a naive patient, I kind of trusted the brand of the institution that I went to. The more deeply immersed I got in the details and the sort of lack of, critical thinking. I don't know what to call it exactly. Once I went in, under the umbrella of that particular brand and then started talking to other experts, I realized, you have to actually go under the brand and actually dig into the details and how good is the oncologist. Most people, it's like, oh, they're at X awesome brand of place that has a good, brand recognition, the Hutch or whatever. And they generally are good, but I was at Kaiser and, I thought the brand was good at Kaiser. And then, I'd see how the oncologists approach things and it was not so good. And then it ended up being a triangulation of multiple sources from multiple oncologists to different specialties like pathologists to smart generalists and community.
Yeah, and just,
Yeah.
and I'll go to you, to Rick, in a second, but on that, all of the big, it's like the bigger and more well-known the institution, the less ownership they take. You're going to get standard of care. You get standard of care at all these places, and standard of care doesn't do any of the stuff we're talking about. I had 3 different large institutions. None of them told me to go out and get this. I got a stamp report. I did get that, but nobody said get a Boston Gene, get a Tempus, get a proteomics. They just don't go that far. They can't. The system's just sort of overwhelmed the way it is to tell patients to start, especially stuff that's uninsured. You're just not going to get that.
Right. Okay, Rick's been waiting patiently.
Okay, so Rick. I'm sorry. Go ahead.
Buddy. I'm glad I wasn't the only one having trouble getting into this meeting today. I was getting frustrated. A couple of things. Kaiser is a great system, Ari, and it has brand recognition as long as you don't get sick.
For bumps and bruises, they do a good job.
Yes. It's perfect if you don't get sick and you like changing your doctor and you want second opinions, but it's not the place to be if you have significant issues. And that's because their business model is based on standard of care. And to get anything more than standard of care is very difficult. I have the T-shirt because I was partially treated when I was diagnosed. I was partially treated at Kaiser and fortunately partially treated at UCSF because they happened to have a contract with UCSF at the time, and that made all the difference. And that sort of got me in along the path where I am right now and what I do. The second thing I really wanted to say was that any doctor who says there's no point in doing testing because you're already on a treatment path and we're just going to stick with that, I personally would fire out of hand.
To David's point earlier.
Yes, to Dave, that's when I originally put my hand up because it really bugged me. We just had this week. We had a guy come in who's treated at the VA, and his medical oncologist told him he wasn't a specialized medical oncologist. He can handle it. He can do what anybody else does. And then the guy asked him for details of his tests, and the guy said, "You don't need that. You're already on a treatment path." We said to him, "You just go back and fire that guy." And if we as patients don't stand up and do that, the doctors will put themselves on a pedestal and they will assume that that's okay to treat patients in that way. And many people will say, okay, well, that's what the doctor said. A doctor who says to you, you don't need a test because you're already on a treatment path, doesn't understand the way medicine has been going the last 15 years or so, which is the path of precision medicine. And yes, you may be on a treatment path, but if you have a certain biomarker that singles you out for a particular drug, that may be a better drug and you may be on the wrong treatment path. Now, David says to me, David, I forget your details, but since you said that you did the PROMISE test, I assume you have a prostate cancer diagnosis. So the rate of testing in prostate cancer is very poor. Somewhere around, I think, I just saw one article. I'm not sure if that's the one I just put in the chat window, but I just saw one that says that men with metastatic and not non yeah metastatic hormone sensitive only get retested at the rate of 9% for NGS. We tell people you need to get retested every year, every 2 years, because the cancer changes. That's not for your germline test. That's not for the promise test. That's for what your cancer makes itself. And the fact that you didn't show anything, or you may not have shown anything on the promise test, doesn't mean you're not carrying a BRCA mutation in your tumor that the doctor won't know about unless he tests the tumor, which he can do with liquid, which is very simple if you have enough of a tumor burden, or he can, or a high enough CTC or ctDNA, or from a tumor sample itself. But I would say to anybody that a doctor who doesn't want to get basic testing, and by basic I mean germline and somatic testing, are not a lot of these fancy tests that we talk about here, because I do think those are out of the ordinary, and I don't think they should be available to everybody, because it would be just way too much of a burden on the medical system. These tests are expensive. You want to go get a SAGE test from Chris Apfel, they cost a lot of money. If you can afford it, God bless you. But at the same time, we have to recognize that there are cost limitations, but we are entitled to basic information. And to me, basic information today means we know what mutations we're carrying. I have other thoughts, but I don't want to take up more of the meeting
Makes sense.
right now.
Thanks for that. Can I just ask you one quick question on
Of
the,
course.
do you think the root cause, so what I see as a failure of truth seeking, perhaps one might interpret it that way from the oncologist point of view, is that because fundamentally there's a lack of interest there, lack of time, lack of reimbursement, and sort of the sort of reimbursement landscape around, you know, getting that additional information? Is there an obvious answer to that question?
I think there's two issues. I think probably the most significant issue for oncologists overall is inertia and lack of education, because many of these people, many of these docs were treated before the era of precision medicine, and they're being asked to adopt it, and they're not ready to adopt it. They live by standard of care, and even then, they don't even follow the guidelines. So the guidelines for prostate cancer say that any man who's metastatic should be somatically tested. In practice, that doesn't happen. There was a paper, I was looking for it. That's what I was looking for just before. There was a paper by Illumina, and I forget one of the big docs last year. Oh, I think it was Neil Shaw. It was Neil Shaw and Illumina at last year's GU ASCO that reported on the frequency of NGS testing, notwithstanding that if you look at the guidelines, if you're metastatic, you must be tested, but it isn't observed.
So you're actually pointing to another mechanic, which is just lack of execution against the guidelines themselves.
Yeah. So you have a bunch of things. One is you have this lack of education. Two, you have this unwillingness to follow the guidelines because, unfortunately, it comes with the territory. A lot of these doctors have egos, and they don't want to be told what to do. They know what to do, but in fact, they don't know what to do. But they don't accept it. I think that cost, all of the issues around payers is huge, because these doctors don't want to be involved in having to apply for reimbursement. They don't want to get into that paperwork, and so they reject. And then I also think that we have to lower our standards of expectation if we're being treated in a community practice environment. We navigate in all of our groups, and Mike Harris has heard us in the pancreatic group. We do it in the prostate cancer group. We do it in the blood cancer group. Get yourself to a center of excellence. Now, not everybody can do that, but a lot of people don't even know to do that. So they go in, they see a doctor who's a medical oncologist locally in a community practice, and they think that's the best they can get. And then they'll come into you. How many people have you heard say, "Oh, I've got the world expert. My doctor's the world expert." Most of the time, they're not even an expert in their own community.
Right. Yep. Anyway, a lot to say on that, but thanks. Mike, you've been waiting.
Sure, and thank you. The one comment I'll add is it may not be a lack of education. It may be that the way that the education is oriented. So in my organization, Trican Health, we come across PhDs and MDs, and a gross overgeneralization, oversimplification that I'm sure is unfair, but I'll say it anyway, which is MDs are trained to narrow the path to a particular treatment path. So they are eliminating options along the way to try and guide you to typically towards standard of care, but that diagnostic path is eliminating different options so they can just end on one. The way that PhDs tend to be trained is more sort of opening, starting from one problem and finding what could be the multiple paths for potential solutions. So it's a beginner's mind. It's more curious. It's more trying to find what the root causes are. And perhaps there's a synergy essentially between these centers of excellence that have NCI designated centers and so forth, where you have the intersection of these two paths to constantly look for what could be the additional root causes. So to my mind, coming across as a caregiver for several cancer patients, when I find those physicians who have an open mind, who are looking for potential causes rather than constantly narrowing things down, that's where I get back to your original question, which is where would I find trust? It's in that person who has that kind of beginner's mindset that's looking for potential solutions.
Yeah, that resonates, and that actually goes back to that chart I was showing. I think one of the sad realities, perhaps, or realizations that when Brad and I talk is it's unlikely the let's call it the system writ large is going to change, in our lifetimes, let's say, of its own volition, getting to, the synthesis of, the PhD mindset and the MD mindset. You've got cancer patients who are like that number of cancer patients, what is it, 20 million in the US today, like 50 million, I think, globally. Like that number is just going up as it becomes more manageable. It's not likely, I don't think, to expect that, the profession of educating MDs to be more beginner mind, like that's not going to happen anytime soon. And so the question then becomes, and I think part of the reason that Brad and I are kind of bullish on actually building some type of more technologically enabled solution is because we don't actually think that change is going to happen on that black bottom line that we were talking about anytime soon. And so the question is, what would it look like to build kind of a, rather than pushing the system, could you build a better thing that then patients in aggregate are able to pull toward a better thing, whatever that ends up looking like, and bend the curve that way? I think that's kind of the thinking here, and that's what we're trying to drive at. I guess in terms of, I'm just looking at our bullets here, but one of the themes that I'm hearing is, there's a range of options. Many of those options are, for various reasons that I think Rick articulated well, are not adopted by, the industry, by doctors. There's a bunch of issues there that are not likely to self-correct. That leaves patients in a bit of a conundrum. You have people, that are in this meeting and people like all of us that are going to self-advocate, really figure out what to do, what's the right thing, who to talk to. But then you think about that's 5% maybe of population. And then you've got a lot of people that think that the community clinic is like awesome and they have the apparent trust, Richard, like you like to say, the apparent trust that their oncologist, because they're an oncologist, know the right thing to do. That leaves patients in, kind of a conundrum of, I can go be like a cancer patient lab kind of person. I can, unwittingly go with, my local oncologist because I don't know what I don't know. And then there's a sort of set of options in the middle that that could be helpful toward patients. And so how do we think about that? So yeah,
And
Richard,
let's use that as a bridge, Ari, to questions 2 and 3 on this slide.
Yeah.
So there are issues around diagnostics adoption, let's just say, and use and application to the extent that they maybe could and should be. What would you think of a subscription shopping offer where you would pay, who knows, like $40 a month, some number like your Netflix subscription to get diagnostic consultation and advice and guidance? Anyone?
And Richard's got his hand up, but I think that's a new hand rather than the old hand. Okay.
You have a
No,
question,
well,
Richard?
it's still my same old hand, but it's for a new purpose.
Go.
So I was just, thinking about the thing that I think needs to be said that is very difficult to get one's hands around, but I think personally, I think it's really important. I mean, if you look at the transmission of any kind of knowledge, when the knowledge is new, it's really hard to figure out if it's good. I mean, you can look in, every scientific discovery practically. You can look at the skepticism around all sorts of things that we now know to be true. But when they were first coming out, people had great reservations about whether it was true. And, we're dealing with very, very important issues here. And to go off of standard of care is, dangerous. It's the safe decision at a certain point to stay on standard of care. And then at a certain point, it probably becomes the safe decision, the safest decision to go off standard of care, and figuring out where that liminal zone is between those two safeties is very difficult. And I would suggest that one of the really valued services that one could do in, what you're proposing and maybe in a diagnostic guide is to give people the wisdom, and I don't really know how to do it. It's probably a lot of discussion to think about it. Give people the wisdom to help them evaluate at what point the flood of information that they can get from all of these diagnostics, some of which are going to have good information, some of which are going to have bad information, how to assess what to do with the flood of information so that you are making the safest, best decision at each point. And, when you're first diagnosed, I'm not sure that the best decision is to go to a really novel test that prescribes something way off standard of care. But, very late in the process, that may well be the wisest course. And I think to help people understand how to make that transition is really, really important. And I don't know quite how to do it, but I think it's really important.
Can I just riff on that for 30 seconds? Because it's really important. And, you think about the new diagnosis. I mean, I think the low hanging fruit there is that actually accurate? Is that correct, given the misdiagnosis rates and things like that? That feels pretty low hanging fruit. The other thing that sticks with me is what I think, Rick, you were saying about the lack of execution against the guidelines or standards. And so there's almost like a check that you can put in, like, well, I've got this diagnosis. Did my doctor do the right thing? Which it sounds like if that's not happening, that's a pretty obvious thing that you could empower a patient to just check that. I mean, that shouldn't be hard to figure out.
Well, medical error is a, yeah, sorry, go ahead.
No, please.
I mean, medical error is a known source of, serious adverse effects. I mean, there are studies that talk about that. And I think that going off standard of care in that elementary way is clearly borders on medical error, if not, steps firmly into medical error. And so, there are all sorts of things that you want to do. I mean, but I think we're talking about I mean, your service might, prevent medical error. There's no doubt that that's in the safe zone. You want to prevent medical error at every stage. And there's certainly, value in the service that does that. But as soon as you start to step off of standard of care, then you get into the transitional zone where the questions get hard.
Richard, do you think maybe that's actually the right framework that you're kind of, I think, pointing at, which is you've got a safe zone and there's like a checking piece and then there's an optimization piece. And, you have to figure out where am I in this?
I want to push back on this argument a little bit because I think we have mental models that come out of chemotherapy that, then don't really apply that well to targeted therapies. And we have ideas that apply to therapeutics, but may apply less well to diagnostics. Diagnostics is information. If you get a 23andMe report that says you're liable for BRCA, you might say, okay, I need to get another test to validate this. It's information. It's when you don't interpret it well and you then go into making decisions based on it, you can get into trouble. I just want to make a distinction.
Yeah.
Diagnostic information does not have the same evidence standards as therapeutic recommendations. And yet we might apply the same mental models to both.
But can I raise something that really concerns me? And it's concerned me, Brad, from the inception of this platform. And I've actually talked a little bit with Mike Harris about this. I feel that some of these tests and some of what you examine here, whilst certainly valuable and very interesting and beneficial to some, it is part of a very elitist model, and it bothers me. If you have the money to pursue it, you have every right to pursue it, and a platform like this helps to inform you. But it can be very expensive to pursue it. Now, we send people to centers of excellence because the centers of excellence are more likely to pursue what we discuss here and be open to it. And if the patient cannot afford to do what is being offered privately, there's more chance they can get it through a center of excellence. They have very little, if no chance, at a community center. It also takes me back to a dilemma which I think few of us in this country appreciate. There are a lot of people who advocate for a one-payer system, but Americans would never tolerate a one-payer system. And the reason is because they don't have choice. And we in this country insist on choice. We insist on the right to buy what we want to buy if we have the money to buy it, which is essentially an elitist healthcare situation. If we lived in Canada, we'd be tearing our hair out. The number of Canadians that we support in ANCAN is considerable. And they come into the group and they cannot access the type of basic treatments that we're getting in the United States because they're in a one-payer system. And if they want to move out of that system, they have to come into the United States and they have to pay for it out of pocket. And that's what a one-payer system means. I know, I grew up in the National Health Service. So, I mean, I'm raising a bunch of issues, and I'm not condemning what we do here, but I think we have to recognize that what we do is because we can afford to do it and not because it should be available to everybody that's out there.
Yep. There's a policy side to that, which is the flip of that, which is, and American medicine, for better or for worse, kind of, we're known to be much more expensive. The drug side is much more expensive, but also most of the drug innovation, or at least a good deal of the drug innovation, comes from here. It could be that, yes, it's very elitist in the short run, but in the long run, some of this stuff gets proven through the elites and then trickles down into standard of care, and that's one way it happens.
Mhm.
So that's a good spin-off benefit to the
Yeah,
extent it's
I was
true.
gonna, I was going to make a similar point, which is that we're focusing on diagnostics and information. And if patients would pay for that out of pocket, then they would be in control and could shop for the care delivery in a way that they don't shop today. And so we don't really have a consumer mentality in healthcare. We go with the flow, we go with whatever our primary care physician offers. And everything is really focused on the provider as the gatekeeper to everything. And so the patient, the consumer, has no influence in the system, very little influence in the system. So part of what we're doing is explicitly going at the very forces that you're describing, Rick, when you describe the national system, which is people won't pay for things that are not reimbursed, and therefore they won't get that scan, and therefore they won't get that information. So we're trying to push for the idea, well, if you could pay for that test that costs, who knows, $100 or $1,000, then you can save downstream in the care delivery, which is, multiples of that cost.
Yeah, but Brad, that means that you've got that $100 or $1,000 to spend right now. Not everybody does. I mean, we ministered to a community for renal medullary carcinoma, which is a horrendous disease, which is highly correlated with sickle cell. We have a lot of African Americans and a lot of Hispanics who are plagued by this disease, and it's a horrible, aggressive, nasty type of cancer. These people don't have two red cents to rub together. It's all well and good saying, well, yeah, I can just write a check for 1,000. These people don't have it. We don't even, we're fighting to get these guys NGS testing. And I have to apologize because I got to call Mike Crosby at 11 o'clock. And so I've got to jump off, which never happens. And this is a fantastic conversation. I wish we could blow meetings like we did today and do this sort of a session more often, Brad. It's fantastic.
Let's continue it. We'll let you go. Thank you for
Sorry,
your
guys.
insights.
Sorry.
No, thank you for your insights. Appreciate it.
Sorry to speak and run. Goodbye.
All right.
I think we've lost a number of people at the hour. I think I'm going to stop recording.